Good afternoon, everybody. This is Jake Galdo with Pharmacy Quality Alliance. Thank you for joining us at today's quality forum. I'm going to give us another 30 to 60 seconds as people slowly join us, and then we'll get started. Thank you. And as we wait, I know I've been talking to you, Randy and Russ, but I'm just going to do a quick audio check now that we've started. Make sure that we're all good before we do jump in.
I'm on. Can you hear me okay?
Perfect. Yes, we can. Thanks, Randy.
This is Russ.
Perfect. Thanks, Russ. I now have us at 1 after, so we're going to go ahead and get started. So good afternoon, and thank you, everybody, for joining PQA today for our quality forum on value-based pharmacy programs, building a medical neighborhood through partnership. We're extremely excited about this highly anticipated presentation with our experts today. As I mentioned, my name is Jake Galdo, and I serve as PQA's Director of Education and Program Development. It's my pleasure to moderate today's session. Before introducing the speakers, I'd like to call your attention to 3 housekeeping items. First and foremost is if you have questions, please use the questions feature within the GoToWebinar, and we'll be able to get those questions to me, and I'll be able to share them with our presenters. Today's quality forum is being recorded. A copy of the slides and audio will be available within the PQA's member resource library within a week. And finally, there'll be a quick survey at the end of today's presentation. Always take the time to fill that out, so that way we can go ahead and notate that and continue to improve our programs. I just want to remind everybody that we will have another quality forum in 2 weeks, Thursday, October 17th, What Makes a Good Measure, and we have the National Quality Forum joining us for that presentation. In addition, PQA's Leadership Summit is fast approaching. It's going to be November 20th to 21st, and we're excited to see all of our members come to that meeting later this year. So I want to take a moment and introduce our 2 presenters today. First and foremost, as Wellmark's pharmacoeconomist, I hope I'm saying that right, Russ, I've been practicing. Russ DeVolder is responsible for the design and deployment of health economics and outcomes research and the comparative effectiveness research to support formulary management programs, pay-for-performance models, and value-based formulary decisions. Russ obtained his Doctor of Pharmacy from the University of Iowa College of Pharmacy and a Master's in Economic Evaluation in Healthcare from City University in London. He is board certified in pharmacotherapy and has held certifications in anticoagulation and nicotine dependence specialist. Additionally, we have Randy McDonough, who's the co-owner of Towncrest and Towncrest compounding pharmacies in Iowa City and Solon Towncrest Pharmacy in Solon, Iowa. He's helped foster collaborative working relationships with several solo and group physician practices in areas such as immunization, anticoagulation, disease state management, and medication therapy management services. He also helped develop and implement health screenings and case management programs for private pay patients and self-insured employers. He was instrumental in implementing medication therapy management services in the Iowa Medicaid Pharmaceutical Case Management Program and provides MTM services for Iowa Medicaid, Medicare Part D, and private pay patients. Of note, Towncrest Pharmacy is also a 2019 Community Pharmacy Innovation and Quality, or CPIC, award recipient, which is given out by the Community Pharmacy Foundation in partnership with us, the Pharmacy Quality Alliance, every May at our annual meeting. With that, Russ, I think I'm going to hand it over to you.
Great. Thanks for the introduction, Jake, and thanks everyone for joining. Definitely excited to share with Randy and everyone on the call really our experience with designing and operating within a value-based pharmacy program. And really what our value-based pharmacy program is looking to do is really to measure, recognize, and reward pharmacies for the impact that they're having on patient care. So kind of using the learning objectives as an outline of how we've structured the webinar today. I'll go ahead and kind of share some of the details and structure around how we designed the program and some of operationally and logistically how it works. Also excited to share some of the early outcomes we've seen in terms of those of how patient care has been improved by pharmacists such as Randy and his team, and kind of the metrics of interest there that we're particularly interested in. And then about halfway through, I'll hand off to Randy, and he'll be able to share his experience of actually being a pharmacy that's looking to do above and beyond kind of your traditional dispensing and counseling functions, and really look to optimize patient care and outcomes. And he'll also be able to kind of share some data on some of the services that he's providing and interventions with the patients that he has in his care. So at a high level, kind of shared really what we're trying to do with the value-based pharmacy program that we developed, we being Wellmark as a health plan, as well as Randy and about a dozen other pharmacists in Iowa and South Dakota. Really is to measure, recognize, and reward them for the impact that they have on patient outcomes. So kind of the general drift of, healthcare is trying to move a little bit away from fee-for-service into more of a value-based sort of reimbursement system. And so this is something that we, over the years, have tried to design and implement. So it is it was a 3-year initial agreement that we did launch the program in July of 2017. It did include 62 pharmacies amongst 12 organizations, so naturally some organizations, including Randy, having multiple locations. We did expand that in 2018. And then also draw your attention to kind of the green bar there. When I get to the slides where I share the results, that'll be the time period that those results are from. So that's the 12 months ending in March of 2019. The only thing I'll highlight on here is that it's a large lift, but I'd say a really fun one to actually design a program like this. So you can actually see all the way on the left, we actually started conversations with Randy and those other pharmacists back in 2015, and it took us 2.5 years to actually officially launch it. So a lot of, great conversation there about, who do we, which patients do we want to touch, which pharmacies should be included, what gets measured. And then in addition, we actually did a small pilot with Randy and his team in there for about 6 months to actually test the model. So as a quick preview, I think Randy does have some information on that pilot that he'll be able to share with you as well. So looking at just kind of the overall objectives of the program, it's a very common objective pretty much of what everyone's trying to do, whether that's, a health plan, pharmacy, provider, even patient, and that's really just trying to improve patient care and outcomes. Specifically within, this program, we're looking to accomplish that by optimizing the pharmacist involvement as part of the healthcare team. Some secondary objectives include we want to be able to quantify the impact that pharmacists are having on some of those key metrics. And we're really interested in doing that because we think it's going to be beneficial if we can create a story or a powerful story that says, here's the impact on patient care and outcomes that these pharmacists have. And here's what we can accomplish by leveraging their training and experience, again, kind of above and beyond those traditional dispensing and counseling functions. And then using that kind of story and impact, want to change, I guess what we would see is kind of the current culture in regards to community pharmacies. And kind of what I mean by culture is I think a lot of us is experienced whenever we kind of go to a physician or a prescriber's office and we are going to receive a prescription, either the prescriber or even a nurse may ask at the very end of our visit, which pharmacy do you want me to send your prescription to? So this is kind of creating the implicit assumption that really all pharmacies are the same. Doesn't really matter where you go, you're going to get the same level of care. So we'd really like to use the outcomes that we see in this to sort of challenge that culture and really be able to promote the use or promote patients to use some of these pharmacies that are doing really good work. So looking at the model, so it gets a little dense here, but there's a lot of decisions that have to be made. So kind of starting at which pharmacies do we want to include in the model? And so how we went about doing this is we actually worked really closely with the Iowa Pharmacy Association, and then also, again, kind of with that dozen pharmacies to really just do some peer identification of which pharmacies have really structured their workflow in a way that's prioritizing patient engagement, maybe more so than just the convenience of getting as much product out the door as quick as possible. So really tried to identify and include those pharmacies that were much more engagement focused. In terms of, so that's kind of which pharmacies, in terms of which patients, we tried to find, our hypothesis is that in order to have the biggest impact, that pharmacists really need to have the opportunity to engage with patients, ideally in a face-to-face manner on a routine basis. And so kind of to use this as a proxy to get this population, what we chose to do is to only include patients that had been identified as having one or more chronic conditions. So the outcome information you see is just on a chronic or on a population of patients that, again, has been diagnosed with one or more chronic conditions. And that was purposeful or intentionally chosen to try to set up pharmacists for the best success. And then other things that we kind of had to make a decision on is, what gets measured, how do we measure it, and then what do we do with that measurement? So I have a few slides on each of those. So looking at actually what we measure. Jake, you can go ahead and go to the next slide here. Yep, so in terms of what we measure, I would say the pharmacies were quite aggressive in designing the program, and they actually chose to they wanted to be measured on 18 individual metrics. So rather than put a full list on here, and I think Randy actually does have the full list later, but we kind of categorized them into 3 different groups. First group there kind of being at the top, we have about half the metrics we would consider kind of process metrics. Process being we're looking at adherence, and we're also looking kind of using compelling indications to check if patients are on the right drugs. Example being if we have a patient diagnosed with diabetes, and they're between 40 and 75 years old, there's a compelling indication to be on a statin medication. So that would be one of the metrics to check for the right drug. At the very top header there, you can see the 4 disease states we concentrated on for those process metrics, so diabetes, depression, cardiovascular risk, and asthma. Felt like those potentially had the most opportunity for pharmacists to impact those. Moving down a row, we assume that if pharmacists are getting their patients on the right drugs, on the right drug regimen, and adherent to it, we'd see improvements in some of those surrogate outcomes, mostly clinical lab values. So a couple of those being looking at A1Cs and blood pressure in diabetics. So Randy will be able to kind of share his experience doing this, but we've actually asked pharmacies to go out and get that data on that subset of patients. So in this case, they're diabetic patients, because we would challenge them to say you don't actually know if you have that patient on the right medication regimen if you don't have the information of how their lab values, in this case the A1C or blood pressure, where those sit today. And then in aggregate, so not at a patient level, but in aggregate, the pharmacies actually send that back to us at Wellmark to be included in the metric calculations. And then the last category is outcomes, or I kind of refer to these as real-world events. And so these actually include emergency department visits, the admissions that patients experience, as well as total cost of care. I would say we feel that these are the 3 here at the bottom, ED visits, admissions, and total cost of care that we focus most on. We feel like it kind of is a little bit unique for this initiative that we're able to see what exactly happened. Like these were real ED visits, real admissions, real cost of care. So rather than some, I'd say, similar initiatives or models that maybe concentrate on adherence and then try to model saying a 10% increase in adherence we project would reduce, admissions by X%. We're able to actually capture to say this is what actually happened. So I think that makes it pretty unique. It's definitely easy, for a health plan to be interested in total cost of care, but kind of one of the arguments is that's kind of a catch-all for what pharmacists are doing as well. So, we have our 4 main disease states up there, but there's a lot of things pharmacists are doing outside of those disease states that we want to be able to give them credit for as well. So going on to actually how we measure those, I would say there's a lot of ways to measure both individual metrics as well as kind of roll them up into a score. So, all have kind of advantages and disadvantages. How we chose to do it is we just kind of did a simple weighting, so you can kind of see the potential points column there, really to emphasize some of those key metrics that we felt we were most interested in looking at how pharmacists were able to impact. And then for each individual metric, kind of our approach to looking at the impact or quantifying the impact that pharmacists had was really to compare that participating pharmacy's performance on that metric to 3 benchmarks. So that first benchmark under threshold is we would compare the participating pharmacy's performance to our average performance of all our pharmacies in our network, both Iowa and South Dakota. So expectation being pharmacies that have prioritized and, again, offering additional services beyond those traditional dispensing and counseling functions, would be doing better than our average pharmacy. Second benchmark under the target there is kind of your traditional self-improvement. So are pharmacies getting better in a current performance period compared to a historic? And then the third one, kind of assuming the assumption would be those two would be true, and then also want to recognize those pharmacies amongst their immediate peers. So this would be those original, just looking at the original 62, now 74 participating pharmacies. Who are the top performers in there, and really giving them credit for being top performers amongst what we would see being their immediate peers. There's a lot of ways to roll it up. Have 18 metrics. We did want to roll it up into a single score, so that's the value-based performance score there at the bottom. And so we wanted to get that so that we could use it in order to do the payment and, again, kind of move for a fee-for-service into more of a value-based pharmacy or a value-based reimbursement method. So this next slide has a lot going on, but it's just trying to highlight again that move from kind of the current state there on the left to where pharmacy reimbursements kind of stuck in this fee-for-service. It's all about which prescriptions are coming into the pharmacy. We recognize that's a valuable function. I mean, we need to be able to get medications to patients in a safe, effective, and help give them the knowledge to take them appropriately. So definitely continue, but we also want to supplement that kind of fee-for-service based activity with saying we think pharmacies that are doing more work in terms of patient engagement, in terms of improving patient outcomes, should also be recognized and rewarded as well. So that's the right side of this slide, to where within the value-based pharmacy kind of program framework is what we're trying to do. So rather than which prescriptions are coming into the pharmacy, it shifts the focus to which patients are coming into the pharmacy, how are the pharmacies engaging with them, and what's the resulting patient outcome kind of impact that's having, and then really tying that performance to saying, and then really, rewarding the pharmacies that are having the greatest impact on those metrics and patient outcomes. So this next slide's pretty dense. It's really exciting for me because I love data, but recognize kind of a lot going on here. So I'll try to break this down a little bit. Kind of starting at the left, you can kind of see a participating pharmacy column here. And so what we tried to do is we pooled the member outcomes within both of these groups. So we took, you can kind of see the N number there, so roughly the 33,000 patients that were attributed or assigned to a participating pharmacy. We pooled all of their outcomes. Same with the population of patients that was attributed to a non-participating pharmacy. Pooled all of their outcomes together. So as you move across the rows there, you can see the experience of those pooled member outcomes in both of those groups. So going from left to right, again, these are kind of what we would call the key metrics that we're most interested in. You have your total PMPM. PMPM is a way we look at total cost of care. In a sense, it's kind of basically equalized in terms of how many members you have. So it's a per member per month cost. So it's looking at the total cost of care. Have that split into medical and pharmacy components. And then we also have two columns for both admission rate and ED visit rate. The two in the middle would be all cause, and then the two on the right would be what we consider potentially preventable. So what we mean by potentially preventable, this is kind of a classic case, would be like a diabetic, goes to Colorado in the winter to go skiing and breaks their leg. We wouldn't really consider that a potentially preventable, ED visit, because it has nothing really to do with their chronic health status. So we try to remove some of those in the potentially preventable columns. Then that final line, you can see the percent difference. So this is really what we're trying to look at to capture the impact that pharmacists such as Randy are having. We're looking at what is the differential in those pooled member outcomes between members using a participating pharmacy compared to those using a non-participating pharmacy. So it's really exciting. Hopefully this is encouraging for some of you that are currently doing, kind of above and beyond those counseling and dispensing functions, to see that pharmacists have a really sizable impact, at least what we've seen in our population. So the shaded areas, again, are those three kind of key metrics or real-world events that I talked about. Interpretation here could be looking at the total PM. We would say that the average member going to a participating pharmacy has 4.6% lower cost of care than a member who's using a non-participating pharmacy. So super fun to be able to present positive results and really be able to say, at least in this time period. And we did, I guess I should caveat, hopefully some of you cut the title, but these are risk adjusted. So again, accounting for differences in kind of the health status amongst the population, as well as stop loss adjusted to try to cap some of the outliers. But it's really exciting to see that, there's reduced cost of care, there's reduced admissions and reduced ED visits that the participating pharmacies are achieving. So it's super fun. Next kind of question I typically get is, kind of what's that look like over time in terms of results? And so this is kind of a longitudinal look here. So the dashed lines, or data, I guess the dashed lines on the left represent kind of the experience of what was happening before we launched the program. And then the solid lines would be since we did launch it again in that July of 2017. So you can kind of see, some movement going on here, but starting at the top there at the admission rate, it's remained relatively below. Members are having fewer admissions consistently compared to the non-participating pharmacies. Same with ED visits, and then actually a consistent decrease in total cost of care over time. So hopefully that means some of what we're able to provide the pharmacies, they're able to be acting upon and finding additional patient engagement opportunities, and the resources they're able to provide to help support kind of the expansion of some of those that they're doing. Kind of another fun look at how the impact, at least from a cost of care, looks is, again, mention those kind of four chronic conditions that we focused some of those process metrics on. You can kind of see the impact that they're having here in each of those kind of subpopulations. So huge impact in patients that have heart disease, and these bars represent confidence intervals, so we'd say statistically significant impact in heart disease and depression. Diabetes, barely non-significant, but probably very strong evidence there that there's a effect there. Asthma is really interesting. So I think we've spent a lot of time, really focusing on asthma population. So hopefully this means that overall, we've had some success. We're actually not seeing a huge difference or a lot of opportunity, and that this is a well-managed, optimized population. That or we're just systematically not doing it very well, but hopefully the former there. The only other thing I would add here, even that bottom one, the other conditions, I think is really encouraging. This is kind of where I get back to pharmacists are doing a lot of things to improve patient care. And so kind of using, again, that total cost of care as a catch-all, this I think really is strong evidence that not only can pharmacists have an impact if you focus them on certain conditions, but they can have an impact holistically, really on any patient. So great job to Randy and the pharmacists for getting some really good results here. Kind of wrap up my portion here. Just want to talk about some of the challenges and opportunities. So I would preface this with saying we've overall had a really great response from the pharmacies participating in the program. I think a lot of that is itself probably, being a pharmacist myself, feels like kind of had been left on the sidelines as healthcare was trying to move from a fee-for-service to, more of a value-based, reimbursement structure, and not necessarily being recognized for kind of what we can do to help that. So I think just being invited to participate kind of in that transition to that value-based care and reimbursement is definitely energized and excited those pharmacies that are participating. I think Randy will hopefully be able to speak a little bit to his experience in the program as well. That being said, anytime you have a new program, there's definitely things that you find that you could enhance. So a few of those are actually, if we want to, everyone's got limited resources, and so there really is a need to identify best practices and really help implement those amongst participating pharmacies. And especially if you want to expand the program, really to kind of have a loose blueprint or framework to say to new pharmacies, here's what's worked really well, in those that are participating today, and we suggest, you start here. So it's definitely an opportunity both for current participating as well as future ones. Prescriber support and collaboration. I think there's a huge spectrum of how well we, I'd say as providers of healthcare services, so pharmacists, prescribers, nurses collaborate, and support each other. So there's a lot of, anywhere on the spectrum you can find, really difficult barriers or some that, are working great together. But, in general, I think there's a real opportunity to, if we go back to kind of those objectives of the program, to really create a story and be able to quantify the impact that pharmacists have and really be able to share this with other providers and be able to, really, again, challenge that culture and say, why wouldn't you want your patient to be getting better care and better outcomes when all you got to do is, really send them to one of these enhanced pharmacies. Data interoperability, I mean, every pharmacy has a dispensing system. Most have, a clinical software system as well. And then we're not the only initiative that they're participating in. So definitely a lot of other ones, and they all have, their own platform where they're getting data from. So any way that we can free up more pharmacist time to spend less, doing IT work and more time in patient care is definitely an opportunity to enhance it. Then the last one is just the validity of outcomes. Not so challenging in aggregate, kind of what I shared today. But really we have, 16 organizations, and some of those, if you have some small pharmacies, you just run into sample size issues where, again, some of those, like one patient can really swing a metric one way or the other. So really trying to tighten up some of the controls on that and give the participating pharmacies confidence that what they're doing is well represented in the outcomes and the performance that we're showing them on those metrics. So just to wrap up, I hope you find that the design of the program, kind of logistics around it, as well as the results, are encouraging and as well as supportive of the impact that pharmacists can have. At this time, I'll hand it off to Randy. I think he'll be able to do a great job sharing his experience in the program, as well as his experience really designing his pharmacy and helping support his team identify some of the patient engagement opportunities and really optimize those patient care.
Hey, Russ, thank you very much. And as you can tell with Russ's presentation, he's been a great partner to work with. He's very responsive to all the pharmacists who are involved in this project, and he makes himself available. He'll set up time to go with you, go over the data. He'll look at the data because we realize that there's also some limitations to claims data and what you're seeing in the real life and how it may not match with what was written in the claims data. And so he's willing to look at that and make some adjustments. So Russ, I just want to thank you and Matt Hosford and others from Wellmark, Blue Cross Blue Shield of Iowa, for one, doing this project, and two, following it through and helping to show some of the positive outcomes. Quickly before I move to the next slide, the background with this, as Russ alluded to, is we did a pilot project at Towncrest Pharmacy, and it was during a time when reimbursement got extremely bad. And so I had challenged the CEO of Wellmark about looking at community pharmacy in a different way, not expecting to get a response. And lo and behold, we did get a response, and a very positive response. And with the work that Matt Hosford started and that Russ is now a part of, we were able to demonstrate the value of the pilot and the impact it had on total cost of care for Wellmark, that then helped to lead to this, this work that we're doing now with the 74 pharmacies. Next slide, please. As I look at why are we doing this from a community pharmacy perspective, well, my whole career has been about how do you transform community pharmacy to really provide clinical services, because throughout my career, I've always heard about medication-related problems, that they exist. In fact, what I've learned over the years is that most, if I go into a patient encounter, I should expect that there's a medication-related problem. And I will tell you, real life has taught me that that's probably true, that there's a medication-related problem existing with that patient. So patients are not being optimized with their medications. That's leading to a lot of negative consequences. And you can see with this particular citation that in 2016, almost $530 billion has been spent on non-optimized medication therapy, and getting close to 300,000 deaths that related to medications not being used appropriately. The causes of this include non-optimized therapy. In fact, what I try to teach my pharmacists and now our residents and our students that come through is you really should be asking yourself, three general questions whenever you're encountering a patient. One, have they reached a therapeutic outcome? Number two, is their medication safe? And number three, is it effective? And to be honest, number four would probably be, is the medication affordable? And if you answer no, I don't know, then obviously that means you need to collect more information from that patient to see what's going on and seeing why they're not optimizing their therapy. We know non-adherence is an issue with 30% of our patients across the board, and that's why so many payers, much like Blue Cross Blue Shield of Iowa, are looking at non-adherence as part of their clinical metrics, because if the patient's not adhering to the therapy, then they're not going to get the outcomes that they need. It's not an easy thing to address non-adherence, because it's not just as simple as someone forgetting. There may be some behaviors that are very deliberate of why they're not taking their medication. So that's where health coaching and motivational interviewing become very important as you work with the patients to identify what's the cause of the non-adherence. Obviously, if a patient's not achieving an outcome, it could be because they're not on all the appropriate therapies. So maybe it's under prescribing, or maybe it's that we're not dosing the patient appropriately. As I said, safety becomes an issue. So is the patient having a side effect? Is that preventing them from taking the medication? Do they have other medical problems for which they're not being treated appropriately? So need for additional therapy. So there's a lot of things that we look at when we do a workup of a patient. And as I'll talk later, we try to do this within the workflow so that we're making each encounter with the patient count so that we can identify resolving medication-related issues. Next slide. And the thing I want to talk about is really the community pharmacy competitive advantage. I've been a community pharmacist as an owner for the last 13 years. Before that time, I was faculty at the University of Iowa College of Pharmacy and left at a full professor level. And during that time, I had a practice site in community pharmacy, but I also had a practice site within a family practice group as well too. But I always seem to gravitate more back to the community pharmacy, and the reason for that is because of access to patients and any patient who walks through that door who may need my help. And so I really see community pharmacists having the opportunity to impact patients and their medications just because of their access to them. Russ talked about the face-to-face interaction. I think we can't, cheapen that impact that it can have, because you have a good relationship with the patient. You develop a therapeutic relationship, which we'll talk more about, but it's really that face-to-face interaction with the patient and that trust that you build with them that helps to have an impact, especially as you work collaboratively not only with the patient, but also with the prescribers. But it's really, the individual pharmacist demonstrating empathy and a caring attitude towards the patient. As I teach my students and my residents, you should look at each patient as if they are a loved one, a friend, a family, a close confidant. What would you do for that person if you thought their medications were not optimized? Well, you'd probably go all the way to the ends of the earth to make sure that things are getting done. Well, that's the way we need to be treating every encounter with every patient, to make sure they're being optimized. Plus, you have other services that the community pharmacists are providing. Delivery services, you got the clinical service that we talked about, you got the different medications you can have access to. We do social determinants of health measuring. We work with our delivery drivers to make sure they're doing some baseline assessments when they visit someone's house, so they can feed that information back to us to see if that is maybe causing some of the problems with the patient as well too. But also the community pharmacist does have a role as being a local drug therapy expert, and it can provide resources, information to health systems, to physician practices, to the patients themselves. It's more difficult to be part of the interprofessional healthcare team because sometimes we're looking on the outside in, but now with electronic health records, sharing of information, platforms that Wellmark has developed and other platforms that are out there, it's getting much easier to really share information about patients. So I see that not being quite as much of an issue as it was in the past. We also are a public health resource. How do we identify issues of affecting our patients, especially as it relates to social determinants of health, and then get them connected with some of the services within the community to help them as well. Obviously, we're knowledgeable about other resources available to our patients, so making sure we're referring to our patients when we need to. Plus, we are a small business, and so we are reinvesting in our communities, and it's important for us to make sure that we are a community partner. Next slide. I talked about therapeutic relationships because this is really changing the perceptions of patients, but it's also, as Russ talked about, it's changing the perceptions of other providers as well too. When I talk about it in a therapeutic relationship with the patient, It's beyond my personal relationship where I get to know Mrs. Smith and I know her family, I know what's going on within her life. But now it's really taking that time and focusing on Mrs. Smith's drug therapy. And with the therapeutic relationship, I make a promise to Mrs. Smith that I will do all that I can within my knowledge and skill set to make sure that they are achieving a therapeutic outcome with safe and effective medication. In return, the promise that she makes back to me is that she will always be open and provide us with information we need to adequately do that. We follow the patient care process. This is something we, continuously teach, not just, the people within our practice, but as we work with other practices to transform their practices, really trying to get that patient care process really embedded within their brain. That, it's all about collecting information and then taking that information, making an assessment to identify and resolve medication-related issues, developing the care plan for the patient, implementing it, and follow up and monitoring that patient over time. So it's a continuous longitudinal care. This is not a one-time transactional event where you fill a prescription. This is you really putting a story together about that patient to ensure they have achieved a therapeutic outcome, looking at them every single time and collecting all that information during that time you have with the patient to ensure that the patient is being optimized. Next slide. So how do we do this within a busy community pharmacy? Well, as I told you, I left academia 13 years ago with the whole purpose to demonstrate you can provide clinical service within community pharmacy. So I knew that I wanted to demonstrate this could be done in one workflow, that you didn't have to separate necessarily out the dispensing function from the clinical services function. Now, with that being said, the pharmacist may still be within the dispensing role, except they're not doing dispensing work. I've got automation, I've got technicians that are doing that kind of work, but the pharmacist is freed up at the end to be able to do their clinical assessment of the patient. And we call that continuous medication monitoring, which is just incorporated within the daily practice and incorporated during the workflow. The division of workflow, I talked about the technician-driven pharmacist-managed dispensing process. I want my technicians to own dispensing. I want them to be the ones. We also have moved into a technician product verification. Iowa has developed the rules that passed legislation last year, and then in June we got the rules written up so that now the technicians can do the product verification, and that frees up the pharmacist more to provide clinical services. But we also have technician-assisted clinical activities such as medication synchronization, getting the patient prepped, getting them ready for the appointment with the pharmacist, so the technicians can help us with that. But in some states, I was not one of these yet, but in some states where technicians can also provide other services such as immunizations. Again, this is a way to free up the pharmacist to do more of the clinical assessment of the patient and utilizing the technicians and optimizing the use of technicians to support that effort as well. A really inexpensive way to help free up the pharmacist within a community pharmacy is to really optimize your medication synchronization, because that does allow you the appointment-based model to really identify and resolve medication-related issues. I tell people, you should get as many patients synced up. And so for our practice, we have about 3,000 patients that feed into our practice, and we have well over 1,500, so over 50% of our patients that are synced up in some way, whether it's traditional medication synchronization or through compliance packaging that we've got them signed up for. Technology becomes very important. We went from having zero automation, zero technology, to, besides our pharmacy management platform, to now where we've got 3 robots and a electronic medication counter. So we got the Parata Pearl, Parata Pass, we got the Parata Max, and we got the Icon. All things that help to improve the efficiencies, improve the reductions of errors within the medication filling, but also just improve the efficiencies and freeing up the pharmacist to provide more services. We use Slack resources. I took a practice that had literally, with 2 pharmacies, had about 12 to 13 employees, and over the last 13 years have built that into 34 employees between the 2 sites. People say, well, I don't know how you can afford to do that. And my response to them is, I don't know how you can afford not to do that. That's why we're available to be successful in some of these value-based programs. And Wellmark, it was our first entry into that, but we have other companies and other self-insured companies and other plans that are working with us, providing us new ways of caring for patients and bringing in new clinical revenue to support that as well. But it's also important that pharmacists become documenters, and really, once they do the workup of the patient, are they doing the e-care plan, or are they doing the care planning process and then uploading that into an e-care plan platform that's standard, so they can be shared amongst other providers, utilized by the payer to identify the interventions that they have made and reimburse pharmacists accordingly. So we got to get used to doing that within the workflow and having the structure to be able to do that successfully. Next slide. What was interesting working with Wellmark, and now we've developed another tool of our own to be able to stratify patients, because once you stratify them, it makes it a lot easier for you to determine what level of care do you need to provide for them. Not everybody's going to need case management. Not everybody will need, a very focused or targeted intervention, because if we look at how they're paying us, which again, that total cost of care is a driver. So it's not just those 4 disease states, but all patients. How do we impact all patients? Because the people who are high and medium risk represent a smaller population. They're more costly, so you got to make sure you're managing them appropriately. But if you're not taking care of those patients who are low risk and they have an event, that's costly to the payer too, and which can affect your metrics. So what we did is we stratified them, and what's nice with Wellmark and that data that they have is they have clinical risk groups, and they have them split up into 9 clinical risk groups based upon their medical conditions and cost. And so what we did is took those 9 levels and tried to risk stratify them, saying, okay, how are we going to manage these patients? Clinical risk group 1 through 4 were those patients that were kind of a lower cost group to Wellmark, so we put them into our bottom low risk patients. All of them receive that continuous medication monitoring, so they're always getting something done. They're always a touch with that patient during the time that they're in the pharmacy, but it's not a targeted intervention, nor is it case management, so it's just during workflow. With the disease state management, that's more of the more of the medium risk patient, where they may have 1 or 2 chronic conditions. Well, what can I do for that patient on a statin? Are they in the right intensity level of that statin? If they have diabetes, are they being appropriately treated? Are they reaching the therapeutic outcomes? All the way to the high risk patients, which is clinical risk group 7 through 9, whereas the medium risk group were 5 and 6. 7 through 9, we're going to be providing case management services for these patients. We're going to do multiple comprehensive medication reviews. Our goal is to keep this patient out of the hospital as much as we can. They already have the risks. We can't reduce their risk because these patients already have the issues. This is mostly now, how do we manage them appropriately so that at least they're not going into the hospital or an ED visit because of the drug therapy. So managing the patients from a perspective of the drug therapy aspects. Next slide. So when we look at the Wellmark value-based pharmacy program, what was important to us is to make sure we're looking at the data, and Russ and his team have done a great job of providing us with a lot of data. In fact, sometimes you feel like, oh my gosh, this data is just overwhelming to us. But data is always good. I'm much like Russ, where I like data too, and it's a matter of me now just sifting through that data to make sure I fully understand it. And Russ has been very helpful when we have some questions about what does this actually mean. But we're actually looking at this data on a regular basis. We're reviewing our performance and seeing how we're doing. And what's nice, you get a screenshot literally of not only how you might be doing individually, but how you're doing in comparison to the larger group of the total network, but also how you're doing amongst your peers within the program as well too. So it gives you some motivation. It's almost like a report card back to yourself to say, what do I need to do to improve my performance? Then you identify the gaps. Why aren't we hitting some of the metrics? What's going on? Are we doing everything we can within the pharmacy? Is there an issue about physicians not responding back to us? Is the patient not willing to provide us with the data? So there's a lot of different things that start to happen as you start working with these patients, especially with some of the more challenging medical conditions such as depression. That's a costly group to Wellmark, and they want us to do PHQ-9s, but that's a different way that pharmacists have approached patients. And then as you try to work more collaboratively with the physicians, they're not understanding, why are you asking about PHQ-9s? And so it's really changing the paradigm, changing the whole thought process, the perceptions of the whole healthcare team. Then you got to review the patients within those metrics and saying what's going on, identify any medication-related issues, and then develop a plan to resolve those medication-related issues. Next slide. These are the outcomes that gives you the full idea about all the outcomes that were being looked at. As Russ talked about, there's the process outcomes. You can see with the different disease states, what they're looking at, with adherence being important with each one of those. But looking at depression, are the patients being adherent to the therapy at the beginning, but then are they continuously doing well over time as they start feeling better? If you look at asthma with the medication ratio and control of PDC, are they adherent with that? Then as you look at the surrogate outcomes, which is collecting that information either from the patient or their provider, but making sure you're documenting that this stuff is actually happening, because as Russ said, if you really don't have that information, how can you optimize their therapy? So if we have issues with offices not providing that information, then we're going to look at other ways of how we can access that information. And that does happen, and that's the real world of transitioning and transforming practices. It's not just us transforming, it's also the providers are going to have to transform with us, parallel to us, because this is the way healthcare is moving. And then we got the total cost of care outcomes, where or financial outcomes, we're looking at the risk adjusted per member per month, the admissions, and also the ED visits. And that's 58% of our rank of our score. So you really need to focus on that, is how do I make sure my patients are being optimized so they're not having an event? And then figuring out what I need to do to improve that patient. Next slide. So when we talk about the pilot, since we have the data on that, and you saw the data that's going on since that time, we took care of, we had almost 2,500 patient encounters during that time that we were part of the Wellmark pilot, and it actually was a 12-month pilot. And you can see that our pharmacists were able to document 17 clinical interventions. So we had a robust clinical documentation system. It was a homemade system that we created. And we kept track of the data because we wanted to match what we were doing with what the claims data was showing on the Wellmark side. And you can see the mean number of interventions per patient was almost 7 interventions per patient during that year. The intervention types included identifying drug therapy problem 50% of the time. So as I told you, if you go into working up a patient, you're going to have a drug therapy problem most time. I actually think 50% on the low side, but with this particular data set, it was showing at least 1 every 2 times you met with that patient, there was a drug therapy problem associated with their encounter. Obviously, patient counseling education becomes important. Make sure they fully understand why they're taking the medication, why are they not adherent, providing some of the coaching and motivational interviewing that you need to be doing for that patient. So that took up a large percentage of the interventions as well too. Then there's other things that we might be doing, more targeted interventions that represent about 7% of our interventions. Our mean patient age was about 59 years of age. This was a commercial plan that we were actually doing it for, so it wasn't a lot of older patients, but 59 years of age was the median, or the mean, and the number of unique medications per patient was 8. So these patients had a lot of medications on board. Next slide. When you look at the interventions by subgroups, it shows that the older the patient was and the more medications they had, the more interventions that we had, which makes sense. So that, and this has been repeated on multiple grants, multiple projects that we've been on. So the more the more medications the patient is taking and the higher risk they are, whether it be more chronic conditions or their age, whatever the case might be, it's always come back that the rate of interventions increases based upon that risk of the patient. Well, that makes sense because you should be providing more interventions for those patients who are considered higher risk. Next slide. And then we actually looked at subgroups within the pilot, and we looked at both high-risk medications, but we also looked at those medical conditions that might be more costly to Wellmark. And you can see again, with depression and diabetes, the number of interventions we made. But then when you look at warfarin and opioids, again, high-risk medications, we had a lot of interventions. So those really represent the 4 major areas that we had most of our interventions for those patients. Next slide. So from my perspective, when I look at challenges and opportunities, some performance metrics were difficult to affect because information was not clear or easily ascertained. And PHQ-9 might be a good example of that, where we had a denominator, but we didn't really know the numerator. So how do we identify which patients we should do PHQ-9? Well, that's more protected information because of the mental illness, and so it's not so easy even for Wellmark to share that data with us. So you're kind of running blindly to say, who do I do it on? And so either you make this decision, you do it on every single patient, to try to capture as many patients as you can, but then you're dealing with, patients who are not very happy that you're doing this, or they're not using the antidepressant, but this is a good conversation to have with the patient, necessary for depression. It might be used for anxiety or some other condition, but it's good for you to capture that information anyway. But it makes it more difficult to affect that just because you don't have perfect data coming in to really identify who those patients are. And that's not true for the other measures. The other measures we actually could identify to the level of the patient, who was who for that particular metric. Prescriber support and collaboration. Well, I've been doing this for a long time. And in Iowa City, as I said, I've been in practice there for 13 years now at Towncrest. We make about 2,000 to 3,000 clinical interventions monthly. We get a response rate of about 90% real time. But there's some things that physicians just don't want to participate in. And, when we ask for lab values such as A1Cs, and they don't want to provide that to us. There's no reason why you need to have that. It's not across the board. It's always, certain physicians, and again, we got physicians who do provide that data, but sometimes it's physicians that have a large volume of our patients. So that does impact us. So the question is, how do we try to affect that, or can we affect it? And if we can't affect it, do we just have to wait it out and wait until that person retires, or what's going on? But those have been some issues and challenges for us over the years, not just at Towncrest and with this particular project, but with other projects that we've done as well too. And what I understand is it's not just pharmacy going through this transformation process. All the providers are going through this transformation process. They're being challenged as well too. And when change starts to happen, and initially everybody thinks, well, we should be in a value-based program. That's great, but you have a tendency to hold on to your marbles as tightly as you can because you realize that some things are being taken away from you. And so I get this from a perspective of all the whole healthcare team. We're all going through the change. Now the question is, how do we start evolving together to really improve patient outcomes? There's also patient attribution changes. So who was attributed to us last month may change next month. And so that's a moving number as far as, you do all this work for a patient, then all of a sudden they're not attributed to you because they change plans or whatever the case might be. So you're always dealing with that moving number of, who's affecting what. And then you got claims level data versus patient level data. But as I said, what was nice is that Russ was very responsive. So we had identified, for example, we had a patient that had the diagnosis of diabetes. The patient didn't have diabetes. We kept asking what was going on. And when we finally followed up with Russ, he looked back and it was actually a claim that was submitted, I think it was by an optometrist, that talked about diabetic retinopathy, which then all of a sudden that followed the patient all the way through. And so that was corrected. But obviously when you got bad data or incorrect, I don't want to say bad data, but incorrect data that's in the claims data, that might be used during the performance metric that can affect you adversely. And then patient acceptance of our role and why we're collecting their clinical information. That's changing the perceptions of patients over time. Next slide. The way we want to recap before we open up to questions is that, we really recognize that the value-based pharmacy program has been a great program. I can tell you from a community pharmacy perspective. And it does measure and recognizes rewards and community pharmacies for the impact they have on patient care. It has shown so far with the data they're demonstrating is that there's been fewer admissions and ED visits and lower cost of care. That's exciting for me to hear that because that's one of the concerns I had in the pilot is, can we affect total cost of care? Well, if you manage therapy better, you should be able to. And so I'm excited to be able to see that that's demonstrating that at this point. But pharmacists need to have the capacity to be able to do this. Not all pharmacies are set up. So when Wellmark really did develop the project, the program, asking IPA and the number of individuals that were involved in it, that involved in setting it up, who should be in it. It really had to be pharmacies that were engaged who already started making those changes within their pharmacy to be able to do this. Then it's establishing new relationships with patients and other providers and other key stakeholders to make sure you're optimizing patient therapy. And my last thing is really pharmacists need to become interventionists. They need to identify and resolve medication-related issues. That's the one thing I think pharmacists really have the training to do. As I showed with that slide that started this whole thing, the number of medication-related issues that exist out there, the cost of it, and the number of deaths associated with it, we have a moral obligation to do a better job of really stepping up our efforts. And with that, Jake, I'd like to open it up to any questions people might have.
Awesome. First and foremost, thank you and Russ for joining us today and for this wonderful presentation. We have a lot of questions and not a lot of time. I want to be respectful that people often run from meeting to meeting. So we're going to try to end our question and answer session in just a couple minutes to give you that time to transition. Additionally, I do want to point out that many of the questions, or some of the questions that have come in, were regards to the recording and copy of the slide decks. Those will be available on PQA's resource page, but if you have any additional questions in regards to that, please feel free to reach out to PQA's education department at education@pqaalliance.org. And so now, Russ and Randy, if you give me a moment, I'm going to kind of read through some of these questions and find one for you guys. So it seems like we have some researchers that have joined us on today's call. They wanted to know a little bit more, Russ, in regards to how you defined preventable ED visits and preventable hospital admissions. Was that published anywhere?
Yeah, so great question. The way that we're using it is we've actually engaged 3M as a vendor that helps kind of provide a dashboard and portal to provide the information. So actually using 3M's algorithm that basically at a very high level is looking at kind of the primary diagnosis code that comes in on those admission and ED visit claims. And they really just maintain a list of what they would consider preventable, or probably I think it's more by exclusion. So they have a list of saying, here's the diagnosis codes that we're going to exclude from being kind of in that group of what they would consider potentially preventable. So it's not homegrown. It is kind of, like I said, what 3M uses. And there may be some resources out there that's publicly available to kind of see the exact diagnosis codes and some of their logic in terms of look back period and things. But good question.
All right. Thanks, Russ. So I'm going to kind of combine a couple of these questions into one global one that Russ, maybe you can take point on, and then Randy, you can add in. But there were some questions around the line of business. When we think about community pharmacy or outpatient prescriptions, they're often subdivided into 4 categories: commercial, Medicare, Medicaid, and cash or uninsured individuals. So when you look at this pilot intervention or these interventions that were being done, were they on a specific line of business, or was this, inclusive of, multiple lines of businesses? Yeah,
so at Wellmark, we're primarily a commercial payer, so we did just isolate it into our commercial population. So at least for our program, I think Randy touches a lot more patients because, again, he has a lot more initiatives in, but just for this program that's, with Wellmark and the Iowa Pharmacy Association and the pharmacists, we are just looking at a commercially insured population.
I'd like to add to that too, and Russ, you can add to this, but when we looked at the pilot, we looked at the number of patients that were Wellmark patients for us at that time. We actually had 1,800, but 2/3 of those 1,800 were actually self-insured. And so as they looked at the program, the self-insured gets to make the decision on that, whereas with the commercial, Wellmark could make that decision. So that's how we settled on the commercial for that particular program.
Yeah, and that's the only other thing I'd add. Yep. Sorry, Jay. The only thing I'd add is that we did go all in on our commercial, so it was our entire commercial population. We didn't sub-segment it out. So all commercial, but all in.
Awesome. I'm going to do one last question, this one directed specifically to Randy. And I like this question because I've had some experiences with some colleagues in this. So in regards to the PHQ-9, if measured by the pharmacist, how do those pharmacists deal with the last question? And for those that may not know, the last question on the Patient Health Questionnaire 9 is assessing suicidality and homicidal thoughts. So Randy, any insight on that?
Yeah. Now you can see why it was not only awkward, asking the question, but then what do you do with the information once you have it, right? Well, the way we've handled that is much like anything else is when we identify that there's some issues going on, we do tell the patient that we want to share this information with the prescriber or with their providers and make sure that they are on board with this and the importance of us to make sure that they're being treated appropriately. Explaining it to the patient about this is really being used to assess the patient's therapy to make sure they're being achieving the therapeutic outcome, and when they got issues like that, this is something that we need to address to make sure that they're being monitored and closely followed with the other providers as well too. But it also causes us to make sure we're following with that patient a little bit more closely as well. So it did change our behavior with that patient as well.
Perfect. Thank you very much, Randy. And for the individual that was interested in that, there is a Community Pharmacy Foundation grant that is about doing PHQ-9s in community pharmacies. My bias is that I was the primary investigator on that, so if you have any questions, just reach out. Now that we are out of time, I do want to point out two last things. We do have our upcoming PQA events, our Caring for the Whole Patient, which is all about leveraging pharmacists and social determinants of health, which will occur right before the PQA Leadership Summit. Both are going to be in Arlington, Virginia this year, and we hope to see everybody there. Again, thank you, Russ and Randy, for joining us, and I hope everybody has a wonderful day.